introduce yourself and then.
Thanks, Dina. Let me know when you can see my screen.
We can see. Thanks.
Are the display settings okay? Yeah.
Yes.
Okay. Great. So thanks very much for the invitation. I'm Martina McMenamin. I'm a data scientist based in the Epi and Analytics for Response unit in the Health Emergencies Programme in Geneva. I'll give the situation update today, but just want to acknowledge all the colleagues across the region and the country, both in WHO, but across the MOH and all our partners to bring this information together. It's really not easy in these circumstances. So I'll go through a quick event timeline. So I'll not go through it all, but we had some early signals between the 9th and 11th of March. 3 suspected VHF cases, all tested negative by Gene Expert in Kasai. At the end of April then, we had 2 sibling deaths negative by Gene Expert in Ituri. And then a social media alert on the 5th of May for 50 deaths reported in Mongwalu. So there was some preliminary investigations done on the 9th of May. And the first investigation report on the 13th of May with 8 out of 13 samples confirmed negative for Ebola Zaire on the 14th. And then the next day sequence to confirm Bundibugyo virus. On this day, Uganda and DRC both declared the outbreaks, and on the 17th of May, the Director General determines the event as a public health emergency of international concern. I think we're all working off the same numbers here, so I'll not go into it too much, just for some context. We've had 4 new confirmed cases in the last 24 hours, 2 in Butembo, 1 in Wacha, and 1 in Kalungata. Just to say that these are 2 newly affected health zones in the last 24 hours. So we now have 13 health zones affected in DRC. This is also, so these are in North Kivu, but this is also because we have not had any testing from Ituri in the last 24 to 48 hours. And I know our INRB colleagues on the call will be able to speak to that a bit more. Just to reflect on, so Uganda are reporting on healthcare worker infections. So we've had 3 healthcare worker infections out of the 7 confirmed cases. So that's nearly 50% of cases are in healthcare workers in Uganda. So just please reflect on the immense bravery of these people working in the Ebola treatment centres. Cumulatively, we have 2,300 contacts listed in DRC, 308 in Uganda. Only around 25% of these contacts are currently under effective daily follow-up in DRC, which is a huge concern given that we don't have any medical countermeasures and contact tracing is extremely important. Just a subset of some of the challenges that the field teams are reporting. We have stockouts of tests, investigation gaps for suspected, so around 50% of suspected cases have had no sample collected. Which is a huge issue for the surveillance. We have around 200 samples in a backlog for testing as of the last update, but again, INRB colleagues will know more, and per capacity for isolation and IPC. This is what the geographical spread looks like as of the report yesterday by the CUSP. So 13 health zones, confirmed 7 health zones in Ituri, 5 in North Kivu, 1 in South Kivu, and 7 confirmed cases in Uganda. So you can see here the geographical spread is extremely worrying, plus we aren't getting tests through the labs in many health zones. Just to say as well, the case in Mitimorhesa in South Kivu travelled while symptomatic and stopped at a couple of health facilities on the way, so we expect to see more transmission chains there also. This is the geographical spread in the last 6 days. So on the 19th of May, we had 6 health zones confirmed in DRC. Now we have 13, again, in the context also of extremely limited testing is very worrying. And I know from people who worked in the 2018-19 outbreak, this is a much faster geographical spread than we saw there. This is just the trends in cumulative cases. We're working on disentangling the trends at a health zone level, trying to reconcile the numbers, but just to show the rate of increases in the suspected cases and suspected deaths over time. Quickly to reflect on test positivity, we know we have this backlog in testing samples in DRC, so the numbers are not reflective of the situation. No information on the number of samples on the 25th of May, so we don't have test positivity, but you can see in earlier days, the test positivity was between 60-70%. It's dropped, but this is a surveillance artifact. And then test positivity in Uganda is around 16%. Quickly, just to show the population density of these areas, just to show the operational challenges that our teams are facing in the field. So not only do we have these huge high population density, we also have these areas affected by conflict. So the operations are extremely challenging for our field teams, and also when reconciling these numbers at the national level, we do have de facto state authorities in some of these. So the government and these authorities are trying to work together to bring the situation under control. So WHO did a risk assessment on the 15th of May that said high at a national level, high at a regional level, low at a global level. However, on the 20th of May, increased this to high, very high at the national, high at regional, and low at global. So we know in the region we have 10 countries that are now undertaking preparedness activities that border the DRC and Uganda. I'll not go through all of this, but just to say the rationale for the determination of a public health emergency of international concern without calling an emergency committee meeting is that the geographical extent, the 2 cases with no apparent links, which now have been linked to a burial in Bunya, unusual clusters of community deaths, and also high positivity rate. I think the other thing that's a major concern is no approved Bundibugyo medical countermeasures, and I know R&D are doing a lot of work on that side. So I think that's my last slide. I'll stop there. Happy to take questions or take them in the chat if we're short of time. Thanks, Dina.
Thanks, Martina. I appreciate a really thorough insight into the current situation. We have a few hands up, and we have one question that's in the chat also. So I'll hand to Nicholas.
Oh, just thanks, Martina. Just wondering why the testing backlog. Presumably, there's some. When you say testing backlog, I mean, I presume you mean that there are samples are collected, but they are not actually tested. Why is that?
Yeah, so we have, I think the last update we had was around 200 samples. I think this is a logistical challenge. So they were sat in Bunya and they were trying to get them to Kinshasa, is my understanding, but I don't know if INRB colleagues want to comment more on that because they'll have much more context than I do. Thanks.
Anyone wants to jump in and comment on that, please do. There's also a question, Martina, in the chat from Ira, which is if there's a first estimate of the doubling time.
No, we don't have an estimate yet, just because of the unreliability of the surveillance at the moment. So this is why in the work that Ruth's about to present, we showed this for a range of scenarios as well. I think when we are able to, there's work ongoing to generate the line list, and we're trying to support country and regional office colleagues to do that, but for all the reasons I said, it's extremely challenging. So we will get estimates, but we can't based on the data we have at the moment.
Did you want to just stop that, John?
Yeah, no, and I mean, just there's also the different questions in the chat and on finding old estimates and what is currently used. So there has been this extraction of the different historic estimates done mainly by Imperial College, there is the link to the, and we can put it in the chat again. It's also, you can find it in the collaboratory as well. So on the one side, there is the PERC, which has all those estimates from Imperial, but it is also in the GREPI from WHO, where the Ebola data have been entered, and there are the historic. I mean, all the there are the links to all the publications that are relevant, and we will also go a little bit later in the discussion on how we will now update if there are any new ones. There is also just recently, for example, people have been redoing some of the analysis more in some more detailed to get some more details from the historic outbreaks. I think that's relevant for this one as well, and so we hope to share exactly that kind of information on the collaboratories so people can use the most relevant estimates as they arise, and keep each other updated as they arise as well.
Okay, that might move nicely into the presentation by Ruth.
Yep.
If you're there, if you can just introduce yourself and share screen, that would be great.
Sure thing. So hopefully, can you see my slides full screen?
Yes.
Awesome. Thank you so much. So hi everyone, I'm Ruth McCabe, and I work at the MRC Centre for Global Infectious Disease Analysis. So just wanted to give a brief overview of the work that we've been doing in the last 10 days to estimate the size of the ongoing outbreak. First of all, just want to acknowledge that this is a huge team effort, and massive thanks to everyone here, many of who have got so many different, competing tasks on their agenda just now, obviously responding to this. So although I'm presenting, please keep in mind that it is everyone here who's contributed to this work. Okay, so essentially, how did this come about? So, I mean, to me, this seems like a long time ago, but I think only 10 days ago, we got this news about the 246 cases and 80 deaths reported in the Eastern DRC. Obviously, that is really incredibly sad and already a huge human toll. But essentially, we were working with our partners. So, for example, Olivier and Martina's team at HQ, and with Dav and his team in DRC, essentially, if this is what we know, if this is what's being reported now, how bad is this? And just to be clear, it's already bad just with those numbers alone. Essentially, is the true outbreak size? Are we dealing with hundreds here? Are we dealing with thousands? And what does that mean essentially for response planning activities? So we pulled together the very limited information that was available to us and used two different independent methods to try and estimate the true outbreak size. So my colleague, Dr. Sabine van Elsland, very helpfully put this figure together for us. So if we look at the two methods very briefly just now, so firstly, we looked at, okay, if there's this many suspected deaths, knowing what we know about the case fatality ratio observed in past outbreaks and the delay between symptom onset to death, does that help us, like how can we use that information essentially then to get estimates of the outbreak size? So that's focused within DRC. We then looked at the, sorry, is there questions or shall I keep going? Oh, okay, sorry. So we then looked at the second bit of information that had come to us on that Friday, and that was to do with the exported cases into Uganda. So essentially knowing what we know about movement across borders, and again about this delay between onset to detection, essentially what does that then also tell us about cases? And of course, the exported case numbers and the death numbers have both increased since we started this, unfortunately. So if we come to the results, so firstly, we looked at the back calculation from deaths, and Ira, I think this links sort of closely to your question about the doubling time. Essentially, we don't know this right now. So what we looked at was a range of plausible scenarios of a doubling time of 10 days, which we took as our central estimate, and then looking at something faster and something a bit slower. Similarly, we don't actually know sort of with great level of confidence what the case fatality ratio is. So we looked at this was observed across the previous 2 outbreaks and looked at sort of plausible bounds around that estimate. So these numbers are updated as of the 22nd of May. Unfortunately, they would obviously be higher again now, but this was with 204 reported suspected deaths, essentially seeing sort of an epidemic size larger than what is being reported in the suspected cases, as we would expect. So just in general, what we can say is the outbreak size goes up as the CFR lowers. And similarly, if we assume a higher doubling time, that also then increases the estimated outbreak size. But really what these initial numbers told us when we were looking at them last weekend for the first time, really is that we were heading towards a situation where actually indeed it is thousands of cases rather than hundreds. So then we can look at the second method then with geographical spread. So this was updated at the weekend, given 3 observed imported cases, and we look at the same assumptions around the doubling time. With our main scenario there just focused on the source population coming from Turi province. And we can see that with those 3 deaths, really that our confidence limit here, we can't actually rule out a size of 2,000, an outbreak size of 2,000. So again, what we see here is similar trends. So if, the doubling time, sorry, I see actually, so that should be faster growth. So a lower doubling time is faster growth, and that means that we have higher higher estimated outbreak size. And this also increases if we expand that source population. So a difference there looking at Ituri and North Kivu provinces compared to Ituri province itself. So just a couple of quick reflections and I'll hand back over to you, Dina. So firstly, just to note the high uncertainty in these estimates. We don't have a good estimate of the doubling time. We're not confident in the CFR. We're using sort of one estimate of the time between symptom onset and death, sort of underpinning these estimates. So it is really important to keep that in mind. Here, our analysis was focused on speed and simplicity because this really was an exercise in helping to inform operational planning rather than anything else. Of course, there are more sophisticated analyses that can be done and that have been done, and we're happy to see essentially that the results really converge on those. One of the reasons that we could move so quickly, and this has already been highlighted by Dina and by Julia, is because of the parameter review that we have in EpiReview and in GREPI. This saved an enormous amount of time over the weekend. And we just want to highlight that, yeah, there's over 1,200 Ebola parameters that we have in EpiReview that are also in the process then of being moved into GREPI as well. Most of those are not for the Bundibugyo strain though, unfortunately. Finally, we just flag that we don't have any plans to further update this analysis. We believe that it served its purpose. This was about giving an idea of how serious, how big this might be, but really there's much more important things to think about now. So, for example, getting those ideas, getting those estimates of doubling time, and thinking about short-term projections. So we won't be, no plans to update this further. So thank you so much for listening, and I'm happy to take questions.
Thanks a lot. Ruth, I don't know if there are questions. Just in the meantime, I'll also just share that there have been, as Ruth was saying, there have been some other estimates now done that we also sort of reviewed, and they're very much in the same ballpark, mostly using the mobility ones as well, but so in that sense, not very different method, but just to sort of make that point as well. So thanks a lot. Nick, go ahead.
How reliable are the death data And I imagine, just noting that that there's difficulties getting diagnostics done, that the confirming deaths as well as cases is with difficulty. Are there some kind of more on the ground estimates based on kind of expected cause of death or something like that, or is this are the actual deaths actually well underestimated?
I think every data currently is still very rough, and one has to take it really like that. So none of those data are a given. This is an area where any data is very difficult to get, and any data and information isn't currently absolutely reliable. So we have to work with a lot of those things.
Ira, please go ahead.
Yeah, Ruth, thank you for that, and everybody. You know, I think the next step forward would be to take these estimates of numbers of cases and project them forward somehow, so we can get a handle on where the epidemic's going. But that's going to require probably much more refined data from probably contact tracing and line lists to get a handle on incubation periods and serial intervals and generation times somehow. So I'm wondering if we're anywhere near getting those types of data, especially line lists from, I know the contact tracing is very limited, but until you can find out, what estimate roughly the generation time, or at least the doubling time's a crude way to do it, and maybe that would be a start. But are we close to being able to get those data to estimate those key parameters? Is my question.
Yes and no. I think we are all we have to give the people on the ground the time and the possibility to actually do that, and then we'll have to see. I think in the meantime, it is really important to get everything ready to show what can be done and what kind of data are needed to do those things, and prepare them so that then they can be used by the people that then have the data in hand. So I think this is exactly this kind of discussion that we need to have. What kind of analysis currently is available for the people on the ground to answer the questions they need to have answered? Among them is also, where does it spread? How will it likely spread? Those are, and like just doing contact tracing and reliable contact measures, containment measures, how can that influence the spread? I think those questions are currently at their hand, and having the analysis pipelines ready to help them make those decisions, I think, is where we currently are. And I think we need to show that from the analytic parts that this is possible, and then that the ways on how they can use it is then the next part as well. But it's also just getting down there, being able to generate reliable line list, I think is another part that, everybody knows that that's urgent, but it just needs a lot of foot to do.
Thanks, Julia. We have another question from Bernardo.
Hi, thank you very much, and thank you for the talk, Ruth. I was thinking about the cross-border movements that you have for your report, because one of the two methods is heavily reliant on that. Do you have some insight into whether that was time appropriate, whether that data corresponds to movements that happen in real time during the estimated origin of the outbreak, and if that matches with earliest case, or whether what's some of the newer estimates that are coming from phylogenetic analysis as well? And do you know are there any plans on following up with more real-time cross-border movements to inform similar models?
Hi, Bernardo. Thank you so much for your question. So indeed, sorry, that's important context I should have covered. So we had 4 different sit reps covering from mid-March till mid-April, essentially looking at that cross-border activity. This is what was available. So it is sort of reasonably up to date in those terms. Obviously, though, there is a lot of caveats underpinning that. We know that not all border crossings necessarily happen specifically at those points. So that is a huge unknown. So I don't think we ourselves are necessarily planning like a lot of further analyses necessarily into that specific part. But indeed, it's really important to look at. I'm sure that there's other groups that will be looking at that. But obviously, all of this is a lot of uncertainty underpinning that.
There's also a post that's in the chat linking to some different mobility data also. Christoph. Sorry, you're on mute. Caitlin, was there something that you wanted to add?
Or do we not hear?
Yeah, we're not hearing. There is one question from Michael in the chat, wondering if you just wanted to.
Yep. So thank you, Michael, for that question. I'm going to have to have a look on that, and we'll pop the answer in the chat because I'm not 100% sure at this point in time. Thank you, though.
So then, Christoph, your hand's back up. Maybe you've fixed the audio.
Can you hear me? Fine.
Yes. Yeah, we're hearing the audio now.
Yeah. Okay. So thank you very much. Two quick questions. One, given the current size of the epidemic and given the estimates of the start date, well, based on the sort of first reported suspect cases and also the TMRCA based on the limited virological data, do you think you can say something about the doubling time? I think the kind of crude estimates come in about 10 days or slightly below. That's the first question. And the second question, in your method, are you getting any inference from the countries nearby that haven't seen exported cases? So sort of the totality of the exports, including the zeros. Thanks, over.
Thanks, Christoph. So I'll answer sort of in reverse. So firstly, what you were saying about inference from other countries not having cases, no, we don't account for that. Again, to reiterate, this was really a quick and simple analysis to sort of inform operational planning. That's absolutely something that we could look at further, but no, for now we don't account for that. Then the second point about the sort of, I guess, the TMRCA and that data about to get at a doubling time, like, oh, sorry, Dina, are you coming in? No, sorry, I thought it looked as if you were. Feel free to. So indeed it does look as if it's pointing towards I guess like that sort of doubling time, but I think there's still like a lot of uncertainty there, and obviously I can say this as someone in academia. I think there's obviously a lot of political sort of I guess opinions and stuff tied up to the start date of the epidemic, but no, we have taken 10 days doubling time as that central point for now. Thanks.
Yeah, And just just to add here as well, there's also the group of the people looking more closely on the genetics and how that might interfere, obviously. And I think this is also a discussion that where we'd love to bring those two groups together so that kind of discussion can be taken further, and we use those sort of on basis on that the same ideas. I think that's an important part. So on the community, we will link those discussions as well.
And I wonder, I know, Seb, you've just posted in the chat, but I know that you also did some outbreak size estimations also. Did you want to come in and talk to those?
Yes, sorry, I only just joined this call late, but we did a similar analysis to and very much inspired by what Ruth had done, and this nice analysis she just presented. So just with a few different assumptions in a Bayesian framework, and then also extending it to a short-term forecast. So speaking a bit to the point that Ara made, and then the other thing we did was to go back to one of the earlier outbreaks where a line list was available and re-estimated some of the delay distributions with uncertainty, which we then also propagated into this updated estimate. So this is I've posted the link in the chat, and we're updating this as more data becomes available.
Yeah, thank you.
And we will put that on the collaboratory as well.
I mean, if anyone else has done any estimations also, feel free to share them in the chat or share them on the collaboratory. I know that there were some outbreak estimations that Epistorm also produced also, so that's also being put on the collaboratory. But Ruth, is there anything else that you wanted to add before we close up? Okay, thanks very much. Appreciate the presentation. We'll now move on to the next presentation. So I'll get Chiara and Dav to come online. Please introduce yourselves and share presentation. Thanks very much.
Sure, yeah, thank you. I'll start sharing my screen. Dav and I have ended up in different buildings, but I'll share my screen, and Dav in the meantime can go ahead. 1 second. Okay, hopefully everyone should be able to see that. And Dav is, on the call separately. Dav, if you want to start away, and I'll just click next whenever you tell me to, basically.
Okay, good. Thank you. Do you hear me?
Yes, we can hear you. Thanks.
Okay, thank you. So I'm in another meeting at Africa CDC. So I am David Bengo from INRB, where I'm leading the unit of epidemic modeling and intelligence. And here we will present you our progress on epidemic intelligence during ongoing outbreak. Next. So we received a mandate from DG of INSP in consortium with different partners, including University of Oxford, Imperial, the team of Ruth, and also INSP, the COSP, where we are working on epidemic intelligence, and the country align different priorities, including a national platform for like a dashboard for having kind of data, different kind of data on Ebola. And what we know, we have a serious problem related to data, especially for example access to data, and so there is a many issue regarding underreporting. So we are working on that. I will present you next slide. And also among the priority, there is a need of developing of transmission modeling in order to estimate some epidemiological parameters. and also to analyze the risk of spreads, so across country and also across different province. And so to align phylogenetic modeling in order to have information about a transmission chain and emerging cluster. And also if once if there is a clinical trial to support clinical trial based on, for example, incident projection and other, and also to support the SJE with managing the incidents, the outbreak for decision making, for example, by having some evidence to help decision making. And also the last one priority is the capacity building on modeling, especially for epidemic intelligence. Next, Chiara.
Yeah, cool. So I think just what's important maybe is to make everyone on the call aware of the epi data generation pipeline, both as it stands now and what we are working towards. So at present, suspected cases are presenting to a point of care. What we're working towards is that patient information will be recorded on an app that's deployed on healthcare workers' phones, or potentially on tablets issued by a collaboration with CEPI potentially, I think, but Dav can speak more to that. Some biological samples are taken for analysis, either PCR confirmation or further downstream genomic sequencing of some samples. And also contacts are being recorded for contact tracing, which is being managed by the INSP. Then currently the INSP and the INRB are stewards of the line list data. At present, and we'll speak more a little bit about this maybe in the next slide, the line list data has kind of delays associated with it, just because while we're working towards a very kind of efficient recording via these mobile devices, right now, like a lot of the data is being generated on paper and sent over WhatsApp and stuff. So collating the line list is associated with many delays. All of this is private and hosted by the INSP and INRB. And then we're building a pipeline that is aggregating up the line list data to the health zone level and to daily incidents, which will be hosted on a public repository hosted by the INRB. Currently, we have data that looks like this. So we have data that looks like daily cumulative cases and suspected confirmed deaths, etc. But to be clear, right now, that data is coming from the SITREPs that are being published by the INSP. They're not coming direct from the line list. There's some step at the INSP that's converting what information we have right now into what's going into the SITREPs, and it's those SITREPs that are feeding into the data repository. But eventually, it'll be directly processed from the line list once the line list starts getting more up to date. Similarly, once we have the line list, we'll be able to provide test positivity, because there'll be information on what samples were taken and the outputs of the tests, and some pre-processed covariate data, which is actually already on the repo, which we can show later. And then all of that data is going to feed into a live situation and risk mapping dashboard, which is active right now, but I guess like a lot of the different components of this pipeline are already active and working, and you'll see in the later slides. But right now, some of these steps are quite manual and being kind of managed by different members of the team. Hopefully soon enough, this pipeline will get a lot smoother, and then accordingly be like quite up to date and quite accurate. Dav, if you want to go through basically the data generation at the point of care and how, go for it.
Yes, so I will talk about the data collection actually. So what is done is we are using DHIS2 tracker, but we have many issues regarding data collection. For example, community health worker need to move about more than 100 kilometers in order to transport data from field or from different from between health zones, so it's take enough time. That's why we have a delay about a number of cases, and it's so for example contact tracing information. So that's why I had a meeting with the incident manager of INSP, and we are working on development of a mobile app that we will connect to DHIS2 tracker in order to have real-time information. So what we intend is to connect this mobile app with Starlink connection, for example, in order to have digitalization of printing of data collection in order to have a line list in real time. So it is a work in progress, and we hope that by the end of this week we could deploy the app for real time data collection. But there is some issue regarding for example, number of phone to give to community health worker for data collection, regarding also internet connection. There is some issue, but we think that we will do our best to have information in real time. Thank you.
Cool. So just to make everyone aware of like what's available right now. So on the GitHub repository, and the link is down the bottom there, which is hosted by the INRB team. We have, I'm not going to go into too much detail on all of these, just in the interest of time, but there are epidemiological, mobility, and population demographic data, some of which have already featured so far in this meeting as input into various models. And I think Linus from Flowminder has shared kind of more information about their data generation process. Every data set on the repository has a README description in English and shortly in French, explaining the data, the source, and how it's been processed, and a machine readable metadata file that basically all of these data sets are being compiled into like builds, which creates one file that's you can read in, and it has all of the data together to hopefully basically like make the workflow efficient for people. And we're operating on a build and release system, where when new data is added, we'll have a new build, so a new kind of consolidated file. And then probably at a frequency of maybe once a day, we'll do releases, where it's basically taking snapshots of the repo such that even if the data gets updated, you can go back and look at previous, like what the data was a couple of days ago. So kind of for posterity, I suppose, and maybe for some more retrospective work down the line. Then for the dashboard, the link is there and the QR code is there, and Bernardo is going to copy and paste in the link. Oh, great, for the dashboard. So the data here is feeding into the dashboard, which I can show you shortly, maybe. Actually, yeah, let me just show you what's going on the dashboard, sorry. Okay, so here is the GitHub data repository. There's a lot of information here. I'd encourage everyone to just go familiarize yourself with it. And if you have any questions or anything, you can reach out to Dav, or we've been tracking issues and incoming data sets on the issues tab. And then here it feeds into a dashboard where we have the confirmed and suspected cases, and you can view the different layers of data that are hosted on the GitHub. So for example, there's the Flowminder data, and then this is a spatial risk map, which was developed by Sam Scarpino, with information here on the model itself. I just don't have time to go into it, but again, please reach out with any questions. We're going to update this dynamically as new data comes into the dashboard. So that kind of summarizes everything. Can you see my PowerPoint now? Yeah, okay, cool. So that, I think that summarizes everything pretty much.
Thanks, Chiara. Thanks, Dev. Really appreciate the sharing of information and the work that you've been doing. We will open the floor for questions.
Everybody's busy looking. Looking into the GitHub. We can do that as well. No, great. I think this is really trying to sort of also, it's a great effort to sort of see how and where we can find the different informations. And I think it will be great if we can sort of continue exchange what people already have done, so that people don't redo the things that have been done, and find the things that need to be continued. Amanda, please go ahead.
Thanks, but I think I'm second. Somebody's before me.
Marvin. It was Marvin. I'm so sorry. Go ahead.
Thanks, Dev. Thanks, Sierra, for the beautiful presentation. Just wondering how we're leveraging the ongoing projects in DLC in terms of digitalization to contribute in updating this data. I'm talking particularly about the EWAS that is also being operationalized in these provinces. How are we ongoing with harmonizing the presence of these tools to contribute to the quality of data? Thanks.
Okay, thank you. So, actually, so what is sure, there is different tools, including DHIS2 tracker and also EWAS. So, but I have some discussion with the incident manager of the Outbreak and also the coordinator of the INS East, who is working on digitalization of health data. So they told me that there is a real need, for the country to have tools. I think that is the question. But what is sure, we can see how to federate this effort. In my presentation, I say that we will, for example, connect our tool to DHIS2 tracker. In order, for example, to see how to add all the information and that's what I can say.
Thanks, and over to Aminda.
Thank you. So hi again, Dav, and both of you. Thank you for this presentation. So just two main questions for clarity. Is everything else set up and just ready to go once you receive the data? And secondly, I just need some clarity on the needs for the digitized data. Is it the epi data, or are you looking at the digitization of all the data for this? So this includes the lab or all the clinical data. So I'm just trying to get a scale of the need here.
So about for the first question, so there is already different model that existing. We have different project. So in modeling we say garbage in, garbage out. Actually, we can note a good model. So there is regarding the quality of data. That's why we need to have a good standard harmonization in order to have good data for modeling. And about the needs of digitalization is not specially for epidata. So we are working closely with INSP, for example, for epidata, but also with INRB for lab data. Sometimes you can see that for one patient, you have an ID for epidata and another one for lab data, and it is very difficult to connect. For example, that's why there is some inconsistency regarding epidata. You can have for one patient we have two results, so we really need digitalization in order to for having good harmonization of data. It is for the current for Ebola, but also for other diseases under surveillance. Actually in DRC.
So sorry, I'm gonna cheat and ask another question based on that. Thanks so much, Dad. That's great. So because there's so many levels of data required, can you work on a minimum product already and tell us what that minimal product is based on the minimum data availability. So this would be what's currently available. So what can you do already with what's currently available, or what's easy to get?
Available data. So what is sure, we have data from SiteRep, and also there is what is sure, there is a line list, but the mainly the issue is the delay of having a line list. It's about 3 days or 1 week sometimes. Yeah, for example, if a community health worker has data with his paper, when there is run, we lost information. So yeah, it is very complicated actually, but yeah, there is some data available, but we need to. So I have a meeting with INSP to see how we can officially add line list on our repository for scientific community.
Okay, thank you.
Yeah, maybe I'll just like clarify as well with the help of this graph, I suppose. Because we've been discussing, I guess like there are some components here that we're saying like aren't there yet. So in the meantime, how we're operating. To be clear, like we do have line list data and we have this pipeline running that aggregates, but we're not pushing it publicly yet. Because the sitrep data is more up to date right now. So like this pipeline is running, but right now it's not. It has all of these associated delays due to the reasons that Dav outlined, which is why right now I think our recommendation is using the digitized sitrep data that is present on the repo. So it is there, but eventually that will be perhaps superseded by if the line list is successfully like implemented with less delays, then we'll be able to run that pipeline is ready to aggregate up the line list and put it straight on the GitHub.
Thank you.
Okay, we have one more question from Nick.
The kind of organizational question. Just I saw the request for assistance for 5 modelers from Go On. Is that to be supporting Dav and team?
So the Gorn one will go through the overall IMST, which is including the different parts down in the country level. So that goes through the IMST's parts.
Oh, I'm ready. So okay, thanks for that.
Yes, and I think we will be, it will be very helpful for us to collaborate also with Goran. I am actually in a meeting with, Africa CDC, and data analytics is one of the priorities, and it's so for the country. And for the country, we receive an official letter of intent from the INSP. That would be very helpful to federate our efforts. Thank you.
No, and just to reiterate, I think there are these different activities ongoing. Obviously, we try to sort of do at all levels, and this includes country level, regional level,
Yes,
and
of
global,
course.
to sort of be part of different groups. And so I think everybody trying to sort of bring together the different strains, different people. I think it would really, I personally believe that if we can sort of share what is shareable, see what people are working on, discuss on the methods, that will bring everybody further. And so our part, collaboratory, is really to try to sort of be not so much the private, we will not use the privately accessible ones, but really discuss the methods, work on trying to bring together the people, keep everybody up to date with what is easily shareable. And so we really would hope to sort of continue that kind of role of bringing everybody together on that side, just for everybody to know, and creative people sort of exchange what questions they have, so that we can then bring it up to the different channels as well.
Great, thank you.
Thanks. And Marvin, do you want to come in?
Yeah, just to supplement, Dave, I think Dave, wonderful job. There's an ongoing effort, I'm sure you're aware, at DRC. You can link up with to kind of like build them around data. Most of coordinated by an ECNS. It would be good to, like, while we respond current epidemic, to like contribute into a long-term effort of having data in GSA. We all know the epidemic is not very comfortable now. We're trying to canalize all these efforts into this unsustainable efforts to link up with an ECN and maybe the CAI with support from with another partners to see how all these efforts help moving forward in a long run, sustainable way.
You what?
I think we're actually 2 minutes over time. I think we have 15 minutes longer. No, go ahead then. I was getting scared. Go ahead. We have more time to discussion. Thanks. I was getting nervous, but we have 15 minutes.
I mean, we don't have any hands up, but if there's any questions, yeah, Finlay, go ahead.
Yeah, hi everyone. My name's Finlay. I'm also based at the Berlin Hub. I have a question to those working on this amazing dashboard. You mentioned in the description that you've linked the shape files to the PDFM database, so the Google Population Dynamics Foundation model. Is that currently used in any of your analyses, or is that just more of a placeholder for future work?
Maybe I'll take this one. As I'm like 99% sure that the answer is no, but I'll also check and get follow-up after the call. I think the dashboard specifically is going to see a lot more development this week. In like the sequential nature of things. Our focus was first getting all of the data, but now the data is in a good place. We're just waiting for a couple of things to come together on the FE pipeline, but all of the components are ready. So we have a bit of time in the interim to be working on the dashboard, and in particular, potentially the spatial risk model.
And then maybe also bringing that exactly to the next part is a little bit on if people have information on what they are currently working on, what they would like to be working on, and how we can exchange those kind of things. I think one area is obviously also the integration of some of the more like the Google Earth AI. There are different people that have different embeddings that might be useful for the analysis to see, but they haven't been evaluated at all. So in how we can have those kind of analysis maybe on in parallel as well. And I'm also wondering how many people have already done like a synthetic line list, maybe even. If the as there are some of the data that is available, I mean, using the one that you have generated from the SITREPs probably is a good way forward. But then what one could also imply moving forward with some synthetic line lists in a sense that could be used across the different models to sort of bring them up to speed and then be replaced by the ones that are coming in. So this is a little bit of question on if people are working on that and are able to share those kind of things. But I also saw that Henry actually was putting up the hand, so we can put that in the chat and take it over.
Yes, hello. Thank you. Yes, it's Henry from WHO in DRC. Thanks for the presentation. I wanted just to add something on what Marvin had said, because right now we are working with an ECNS in terms of making up standards and so on, which have to contribute to national plan of informatization and so on. So maybe it will be important that Dave and the other colleague join us in this meeting, because what we want is, as said Marvin, we want to avoid kind of a fragmentation in the system. You know, in DRC we have many tools, many standards that are not aligned with the national part. So it's necessary and important that we come together to see how we can align all of these initiatives in what the ECNS will give us as a standard and a protocol to follow. Thanks.
Okay, maybe I can, Dr. Henri, normally we should have a call. I will call you just after this meeting, and I will also discuss with Dr. Eric. I will show him. So we will discuss on that, and I will also discuss with Dr. Eric to see how we can align our effort to what is done for the country.
Going on, yes. Okay, thank you. Fine. Yeah.
That's great. We are coordinating on all levels. That's great. And I mean important. So for the people around that are waiting for these kind of line lists, I think we need to also sort of be mindful of all these kind of this kind of coordination is extremely difficult. But while we wait, I think we can already do a lot of coordination and seeing what we have, who has what and what we need, so that the analysis that is planned actually helps on the ground and isn't just an academic exercise, as we sometimes call it. Chiara.
Okay, fine. Thank you.
I think just very quickly on that point, I'll emphasize to everyone that the INRB team is going to be keeping people up to date on what exactly to expect to avoid this situation of duplicated efforts on the issues tab of the GitHub repository. And feel free to open an issue if there's something perhaps that you're planning on I guess working on, so then we know not to duplicate that effort as well. Yeah.
Thanks a lot. That's great. Nothing additional. Any other things, or maybe things, maybe also on the future of this group and of this call? We were thinking that it's a little bit difficult to see how quickly this all is evolving, how quickly we want to re-meet. We're happy to sort of meet the needs of discussing, but it's also to sort of then see if people have things that they would like to discuss with others. It's a little bit like a pre-peer review that you can see for anything you have, exchange of things. We were for now planning to have another meeting of this kind next week. And please come forward if you think you have things that you would love to discuss, questions that you have, so that we can plan accordingly. That would be the other question. And I'm not sure if we followed all the questions on the. We followed all the questions on the as well.
I think there's just to mention there's a lot of links that have been dropped into the chat, and people won't have access to that when this call finishes. So what we'll do is we'll make sure those links we're posting in the collaboratory. So if you join that community, that's where we'll be dropping any links. And if people are sharing through additional links to their work, that's also where we'll be sharing it. So please join there and keep up to date. We'll also announce the upcoming webinars that will be done, and if there's any specific gaps that come through to us around analysis, that's where we'll be sharing any information about those. But I think we can close a bit early and give people that 5 minutes back. I'm sure we're all busy at the moment. So really appreciate the time of presenters today. I know it's a busy time for everyone, so appreciate your time to present. Please reach out to us if you'd like to present in upcoming calls of the work that you're doing. And we'll see you online and in the collaboratory. Thanks, everyone.
Thanks.
Thank you.
Thank you so much.
Thank you very much.
Thank you.
Thank you.